Good afternoon, all. At the outset, I would like to thank the Diabetes Awareness Prevention Committee, IMA Tamil Nadu, and Dr. Balamurugan sir, and Shivakumar sir, and Dr. Ranjit sir, and Dr. Anand sir and Hariharan sir for giving me this opportunity to present in this esteemed forum. I am Dr. Raj Kamal, going to present the topic on diabetic nephropathy, screening protocols and referral thresholds, which is nothing but how to screen and when to refer. To start with, what is diabetic neuropathy? It is defined as a chronic condition characterized by gradually increasing urine albumin excretion, blood pressure, and cardiovascular risk with falling GFR and eventually end-stage renal disease. So this is on the left, we will see the healthy glomerulus, and in the right, we are seeing the diabetic glomerulus. As the image is self-explanatory, in diabetic glomerulus, and the apparent arteriole, there will be vasodilatation, and in efferent arteriole, there will be vasoconstriction. And there will be basement membrane thickening, and podocyte hypertrophy and foot effacement will be present in the diabetic glomerulus. So classically, diabetic kidney disease includes the classical diabetic nephropathy and the non-classical diabetic nephropathy. But chronic kidney disease refers to all the kidney disease of any etiology, including non-diabetic related causes. So coming to the major question, screening timeline for diabetic nephropathy. For type 2 diabetes mellitus, you should screen the diabetic nephropathy at the time of diagnosis. For type 1 diabetes mellitus, you should screen at 5 years after the initial diagnosis. And thereafter, we have to do an annual screening for type 1 and type 2 diabetes mellitus. So how to screen? There are two pillars for screening diabetic nephropathy, one of which is urine albumin creatinine ratio and estimated eGFR. What is urine albumin creatinine ratio? It is the ratio of urine albumin, which is measured through turbidometry method, and urine creatinine, which is measured by Jaffe's method. And we are taking the ratio of urine albumin and creatinine ratio. Usually, a spot morning urine sample is preferred. So the normal value is less than 30 milligram per gram. And if it is 30 to 299 milligram per gram, it is stated as microalbuminuria. And if it is more than 300 milligram per gram, it is stated as macroalbuminuria. So there are some instructions before we are doing the urine albumin creatinine ratio to avoid the pseudoalbuminuria. So the patient should not undergo any vigorous physical activity for 24 hours before taking the urine albumin creatinine ratio. And the infections of urinary tract should be ruled out, and any acute illness should be ruled out, such as fever, and uncontrolled hypertension and diabetes should also be ruled out. And a patient on menstruation should be avoided testing for urine albumin creatinine ratio. So why we are doing urine albumin creatinine ratio, which is recommended as of now, rather than doing 24-hour urine collection, which was a traditional method used in the past. Because urine's albumin creatinine ratio is high convenient for the patient. It is a single sample, whereas in 24-hour urine collection, it is a cumbersome procedure which involves collection of urine for 24 hours, in which the urine may spill or the patient may miss to collect the urine. And the accuracy for spot urine albumin creatinine ratio is high, whereas it is variable in 24-hour collection. And it is also cost effective, and current gold standard method is spot urine albumin creatinine ratio. So the diagnostic pathway for urine albumin creatinine ratio, initially we are doing this urine albumin creatinine ratio. If the result is more than 30 milligram per gram, then repeat the test over next 3 to 6 months. So the confirmed diagnosis can be made only if 2 out of 3 samples are positive. So further, we classify this albuminuria into 3 categories, which is A1, A2, and A3. A1 is less than 30 milligram, which is normally or mildly increased, and A2 is 30 to 300, which is moderately increased, and A3 it is greater than 300, which is severely increased. So we have seen one of the pillar, which is urine albumin creatinine ratio. Now we are going for eGFR, which is the next pillar. How do we calculate eGFR? It is calculated by various formulas, but we don't need to worry about the formulas. We have the app, which is available in both iOS and Android platforms. I'm showing an iOS platform. You can open the eGFR calculator and you can select the CKD EPA creatinine equation, which is the preferred method as of now. And you have to enter the serum creatinine, which is done by Jaffe's method. And we have to enter the age, and you have to select the gender of the patient, and thereby you get the results. So it is simple as that. Just clicking of an app, it gets the eGFR. So why are we using CKD-EPA over the traditional MDRD formula or Cockcroft's Gauss? Because it has higher accuracy. The older MDRD formula tends to underestimate the EGFR in EGFR range. So CKD-EPA is significantly more accurate, and it is validated by National Kidney Foundations. And with the clinical relevance, catching the decline from 90 to 60 EGFR is critical for initiating the standard therapy, which includes SGLT2 inhibitors and ACA inhibitors. So this is the EGFR roadmap staging, which includes the 5 stages: G1, G2, G3A, G3B, G4, and G5. And G1 includes greater than 90, G2 60 to 89, G3A 45 to 59, G3B 30 to 44, and G4 15 to 29, and G5, which is less than 15, which is obviously end stage renal disease. So we have seen the two pillars, which is EGFR and albumin creatinine ratio. We are combining these two, and we are creating a heat map, which is popularly called as heat map for diabetic nephropathy, which consists of green, yellow, and orange and red areas. We are more concerned about the areas which include the orange and red, which should be referred to a nephrologist for further management. So this is the natural history of diabetic nephropathy, which is the Mohansen evaluation history, which consists of 5 stages. Stage of hyperfiltration, in which the EGFR will be increased and the kidney size will be increased, and the silent phase, in which the structure of the kidney will be normal, but there will be an ongoing basement membrane thickening. And stage of incipient nephropathy, which is the stage 3, where there is microalbuminuria onset, and stage 4, which is overt nephropathy, where we will get macroalbuminuria and eventually end-stage renal disease, which is corresponding to stage G5. So this picture depicts the natural history of diabetic nephropathy in type 1 DM, in which there will be glomerular hyperfiltration, there will be increased EGFR and increased kidney size, progressing to silent and incipient stage. Over there, it leads to end-stage renal disease. So what do we do? If your patient is in green zone, you have to monitor the patient every year and optimize the lifestyle modification and glycemic control. If our patient is on yellow zone, we have to monitor the patient twice a year and consider starting AC inhibitors and SGLT2 inhibitors. If our patient falls in the orange year, we have to monitor 3 times a year and monitor for the complications such as anemia and bone mineral density issues. And if the patient is on red zone, we have to monitor 4 times a year and properly refer to their nephrologist. So we have seen how to screen diabetic nephropathy, and when to refer to a nephrologist. We have certain conditions. You will see one by one. If your diagnosis is uncertain, if you are not sure of your diagnosis of diabetic nephropathy with atypical features such as active urinary sediment and rapid onset, you should probably refer the patient to a nephrologist. And hypertension, difficult to control. If your patient is not controlled on hypertension with high BP, even after starting 3 agents, one of the agents should be a diuretic, then refer the patient to a nephrologist. And if the patient is having fluid overload, irrespective of starting diuretic, which is diuretic resistant volume overload, refer the patient to a nephrologist. And if the patient is not responsive to oral iron of anemia, which is due to chronic kidney disease, where the patient needs erythropoietin, it warrants a proper referral to a nephrologist. And if the patient is having abnormal bone chemistry, it triggers the treating physician to refer to a specialist for further management. And if the EGFR is 30 to 45 ml per minute per 1.73 meters square, it prompts that the physician should refer the patient to the nephrologist. And if there is massive proteinuria, which is 2,200 milligram per grams, or nephrotic range of proteinuria, it refers immediate nephrology referral. And if you have a baseline EGFR, and if the patient is coming for your follow-up, and if the EGFR fall is more than 5 ml per minute per 1.73 meters square per year, this patient has to be referred to the nephrologist. So this is the summary of referral criteria to a nephrologist, which we have already discussed. And last, final word about cardio-renal connection. If the patient is leaking albumin, the albumin is leaking in the vasculature. So higher level of urine albumin creatinine ratio and decreasing EGFR are independent and additive risk factors for cardiovascular morbidity and mortality. Macroalbuminuria is the highest risk factor for putting the patient into heart failure and sudden cardiac death. In our heat map, if the patient moves from green to red or orange zone, the patient is at higher risk of cardiovascular morbidity. So the key takeaway is we have a dual pillar screening, which includes urine albumin creatinine ratio and EGFR. And albuminuria is the important predictor of both renal progression and cardiovascular morbidity. As soon as possible, we have to do early intervention, and we have to monitor the cardiac opinion also, and proper timely referral. Do not wait for stage 5. Refer to a nephrologist if the EGFR is less than 30 to 45 ml per minute, or if there is complications like refractory hypertension and anemia. Thank you, sir.